The following podcast is part of a certified educational activity titled The ADC Wave in Small Cell Lung Cancer, Emerging Evidence and Practical Considerations for New Options on the Horizon. Access the entire activity and complete the post-test at peerview.com/XYC860. Downloadable slides and practice aids are also available.
Hello, I'm Lauren Byers. I'm the Thoracic Section Chief at MD Anderson Cancer Center in Houston, Texas, and I'm very pleased to be with you today. And we'll be talking about the ADC wave in small cell lung cancer, emerging evidence and practical considerations for new options on the horizon. Our goals for today will be to talk about what are the rational ADC targets in small cell lung cancer, how to interpret the latest evidence in ADCs in small cell lung cancer, and also which factors and considerations to keep in mind for optimal integration and use of antibody-drug conjugates in patients with small cell lung cancer. To start, we're going to talk first about the currently available therapeutic options and guideline recommendations in the management of patients with extensive stage small cell lung cancer. Small cell lung cancer has really been a challenging cancer for many years, and I'd say for many decades. And there are several reasons for this. One is that many of the patients have a history of smoking, and so they often have had comorbidities that can also contribute to some of the challenges of taking care of these patients. We know that small cell lung cancer is a very aggressive, rapidly progressive form of cancer. And so this also has been limiting in terms of, not wanting treatment delays. And sometimes that has made it more challenging to get patients screened for clinical trials. And then also because of the aggressive nature of this disease, in many instances, patients have not been able to receive later line treatments. On the upside, the standard chemotherapy was easy to administer and was fairly straightforward because the chemotherapy didn't change for a very long time in terms of the standard of care. And some of the other limitations included a really limited understanding of the biology of small cell lung cancer, in contrast to other lung cancers where there are multiple biomarkers. It's only been very recent that our group and others have really started to understand that small cell lung cancer has distinct therapeutic targets and how we can leverage those going forward. And finally, another thing that had been a limitation was that there have been relatively few models to study small cell lung cancer, but that's also an area that really has been advancing and I think is making a big difference in terms of how we understand this and think about taking more novel therapeutics forward. So here you can really see that we're starting to see an acceleration in terms of new drug approvals for small cell lung cancer. One of the major landmarks was with the addition of anti-PD-L1 therapy with atezolizumab and durvalumab to what had been the very long-standing chemotherapy backbone, and that provided a modest benefit for many patients. But since then, we've had several new therapeutics that have come into the small cell space. These include lurbinectedin, as well as the T-cell engager tarlatamab, and also with the use of durvalumab now in earlier stage disease with limited stage patients. We also saw new indications in 2025 with maintenance therapy with addition of lurbinectedin in combination with atezolizumab, and now having further data coming out with tarlatamab in terms of how to use this in the second line setting, as well as some newer data coming from some of the conferences in terms of activity of tarlatamab when used in the maintenance setting. So I think we can anticipate that the landscape for small cell lung cancer, especially extensive stage small cell lung cancer, is going to continue to evolve quickly. And so you can see, what the recent treatment algorithm has been with the combination of chemotherapy and immunotherapy with anti-PD-L1 agents. And in the second line setting after relapse, using either standard chemotherapy such as irinotecan and topotecan, or lurbinectedin, which was approved in 2020, and now tarlatamab, starting more recently in 2024. So again, I think these are really important landmarks for this disease, and I think we're going to continue to see this advancing further. And if you look at the bottom part of the slide, again, you can see, now that there really is, sort of a new option in the second line setting that we hadn't had previously, with data supporting using tarlatamab in that setting. And then in the third line, frequently looking at things like topotecan or lurbinectedin. One continued challenge, though, remains the attrition rate in extensive stage small cell lung cancer. So we know that most of these patients, in spite of receiving immunotherapy, will have disease progression. And so we really continue to need better options for these patients. And just, as a reminder, over half of patients who have relapsed small cell lung cancer may not receive subsequent therapies. And we're going to start by talking with the antibody-drug conjugate targets in small cell lung cancer. So I think one of the very exciting class of therapeutics now that has really entered into the space for patients with small cell lung cancer are the antibody-drug conjugates. And we think of this in terms of being like a targeted chemotherapy where there's an antibody component that binds to one of the surface targets on the surface of the cancer cells, and then brings with it a payload that can directly kill the cancer and deliver the payload to where the cancer cells are. And so some of those aspects that determine how well those therapeutics work have to do with the target itself, as well as the payloads and other features in terms of things like bystander effect that can also enhance response to the treatment. And here you can see some additional aspects of the antibody-drug conjugate mechanisms of action. The antibody engagement leads to a payload-independent anti-tumor activity, and this works through several mechanisms. And this includes stimulation of the immune cells and disruption of the receptor dimerization. Most of the ADCs are internalized into the tumor cells, and the payload is released from endosomes or lysosomes and has a direct effect then on the cells, leading to cell death. One of the potential advantages and benefits of this approach is that there can also be bystander effect, where some of the payload can also kill some of the neighboring cancer cells that are present. This slide shows a number of targets that have been developed for antibody-drug conjugate therapies, not limited to lung cancer or even to small cell lung cancer, but you can see that there are quite a number that are being regularly used across many different cancer types. And again, there are different ways that these are engineered in terms of trying to get the most benefit and most activity for these individual cancers. A couple of the targets that I want to highlight here include targets such as HER2, TROP2, c-MET, which are all playing various roles in the lung cancer space. And then for small cell lung cancer, there are a variety of new targets that are being explored in clinical trials. And these include targets such as DLL3, which is also the target of tarlatamab with the T-cell engager, CD56, TROP2, B7H3, and SEZ6. So next we'll talk about emerging clinical efficacy and safety data for novel targeted ADCs in extensive stage small cell lung cancer. At the World Lung Conference, there was a session presenting new data from several different antibody-drug conjugates, and I'm just showing some examples here. You can see the drug names as well as the targets that are being leveraged for these therapeutics. Again, some of these are very familiar. So DLL3, for example, is the target for tarlatamab, and in this study of the IDE849 was using an antibody-drug conjugate that targeted the DLL3 surface target. And again, other therapeutic targets for the ADCs include the B7H3, SEZ6, as well as TROP2. And I think one of the things I just want to highlight here is that, these waterfall plots look very different than what we have historically seen for patients with relapsed small cell lung cancer, where often patients had very limited response and very few patients were responding. But what we are seeing here is that, many of the patients are getting benefit in terms of response, as well as encouraging signals as far as survival and other outcomes, in these early studies. And just to compare a couple of these in terms of the differences, but also the similarities. So again, these are examples of the current anti-ADC therapeutics that are in the small cell lung cancer space, targeting these different surface targets. But one thing that is common across all of them is that for each of these, they're using a TOP1 payload. So that is very similar. You can see again here, encouraging response rates, as well as encouraging progression-free survival data, as well as survival data for many of these, especially when we remember that this is in patients who have relapsed small cell lung cancer and often have been traditionally very resistant to next line traditional chemotherapy, for example. Some things to keep in mind with the antibody-drug conjugates, because of the payload, the common toxicities include hematologic toxicities. So patients may have thrombocytopenia or anemia, especially if they are receiving treatment for a longer duration of time. But also we have seen that patients can have a very rapid and early response, and that frequently goes along with patients having improvement in cancer-related symptoms. We've also seen encouraging results in patient populations that often have been very difficult to find therapies that are effective in providing good benefit, but we have seen good signal of activity in patients, including those who have brain mets, who have platinum refractory disease, and have had several prior lines of therapy. One other thing that I think in general with antibody-drug conjugates is important to keep in mind is that some patients may have interstitial lung disease or pneumonitis. And so being very aware of those symptoms and doing additional workup as needed if patients develop new symptoms in terms of some of their pulmonary symptoms, cough, shortness of breath, hypoxia, etc. That these are things that we know are important to further work up early. So here in this table, I'd like to highlight some of the novel ADC therapeutics that are being tested in patients with small cell lung cancer. So the first one in the table is SHR-4849, which has also goes by the name of IDE849. This is an antibody-drug conjugate where the target is DLL3. And just as a reminder, that's the same target as tarlatamab. The therapeutic here with this SHR-4849 uses a TOP1 inhibitor payload. And the response rates seen in that trial were very encouraging at 73%, with a duration of response of 93%. The second ADC, which is QLC 5508 or MHE088C, this is an antibody-drug conjugate targeting B7H3. Similar to the previous ADC, it also is using a topoisomerase 1 payload. The median progression-free survival was 5.9 months, and the median overall survival with this therapeutic in patients who had relapsed disease was median overall survival of 11.7 months. And this, I think, is really striking because we know that with the current frontline extensive stage small cell lung cancer treatment with platinum etoposide and anti-PD-L1, that the median overall survival in those frontline patients is around 12 months. And so here, seeing something similar in terms of the overall survival in these relapsed patients who received this B7H3 ADC is really quite a striking and different kind of level of activity than what we have seen previously with many second line and third line therapeutic options. And this trial is currently has an ongoing phase 3 trial to further assess its activity and a possible, future looking in terms of, this could possibly be a new standard of care depending on the outcome of these phase 3 trials. Another ADC that was also presented in the same conference, in the same session, was I-DXd. And that is targeting also B7H3, again, with a TOP1 payload. And it is similar to the other antibody-drug conjugates, very high overall response rates for a relapsed small cell lung cancer patient population of 48.2%, and duration of response showing 5.3 months with a PFS of approximately 5 months and a median overall survival of 10.3 months. And again, for patients in the relapsed setting, where often the duration of second or third line therapy, has been very modest. These are, very different numbers and different outcomes. And the I-DXd study is also having an ongoing phase 3 trial to further expand, what the data supporting this particular ADC. And the last one is a relatively new target, the ABBV706. This targets SEZ6 and also uses a TOP1 payload. Here, at the conference, I presented this data, and the overall response rate was 77% in second-line patients and approaching 50% in patients with receiving treatment for third-line therapy. The median duration of response was approximately 6 months, and the median progression-free survival was approximately 6 months. And that is now moving forward to be further investigated in phase 2 and phase 3 trials. So I think just a couple takeaways here before we move on. We're seeing high response rates for several of different therapeutic targets with the antibody-drug conjugates. Common toxicities are hematologic, and it's important to be aware of any symptoms that may suggest pneumonitis, since that can be a potential class effect of antibody-drug conjugates. But a very encouraging signal in terms of the response to many of these, as well as the durability of benefit, including in patients who have very refractory or, traditionally difficult to treat small cell lung cancer. Next, we'll talk about the practicalities of integrating emerging antibody-drug conjugates into the clinical landscape of extensive stage small cell lung cancer. So I think some of the things that we have to take into consideration is, of course, who are the patients and what type of disease or treatment-related factors do we need to consider when we're determining treatment selection as well as sequence for our individual patients. And so this may include thinking about, what is the prior therapy that they've received, what are their comorbidities, and how might that impact toxicities or tolerability, and related to this, their performance status. I think there are some really important key concepts here, and I think that with the second bullet, it really emphasizes that it's important to learn and to recognize how to manage these patients if they start to develop toxicities related to the antibody-drug conjugates. And we've talked a little bit about that. In particular, I think, learning from other areas of oncology, for example, such as in the breast cancer space, where they've been using antibody-drug conjugates for quite a long time. And I think that they have become very, in tune in terms of being aware of the toxicities and to be very proactive in terms of managing these. And this is the same thing that we need to be doing in the lung cancer space. And so again, common toxicities to be aware of include interstitial lung disease, symptoms of pneumonitis, GI toxicities that can occur, for example, with diarrhea, and then the hematologic toxicities with myelosuppression, as well as, depending on the specific therapeutic, there may be ocular toxicities, mucositis, or other symptoms that are observed or arise. And I think we have all definitely benefited from having multidisciplinary teams where we have expertise in different areas that can help with managing and treating these toxicities. And so it truly, as for much of our work that we do in oncology, as a multidisciplinary team may include, for example, the pulmonologists or other medical care team members in taking care of these patients and treating any ongoing toxicities. And the last thing I want to touch on here is that, with many different ADCs coming into the space, as well as other therapeutics in the landscape for small cell lung cancer, it's going to be really important to understand what are the biomarkers and how can we start to really personalize each patient's treatment based on the biology of their cancers and their biomarkers. And I think this is something where, more and more we're going to have biomarkers that we can use for small cell lung cancer, which we had not have previously. But I think this is something where, especially, as we have more options to choose from, we're going to need to know, how to pick the right patient for the right treatment and the right time in their therapeutic journey. So I think that's something that is really exciting and will continue to evolve, rapidly, hopefully, in the next, year and coming years. So I think going forward, as the landscape continues to evolve and move quite rapidly, we know that we have, therapeutics that we can turn to already, things like lurbinectedin, as well as tarlatamab. And so I think that, having the antibody-drug conjugates will be, very important for our patients, and having more options. A couple of things that you might think about in terms of the antibody-drug conjugates is that these often are fairly straightforward to administer to patients. And the toxicities are those that we, have familiarity with in terms of the hematologic toxicities. I think one thing that I have been very encouraged about is that many of the patients who are receiving antibody-drug conjugates for relapsed disease have demonstrated very rapid responses. And we know that that's very important for patients, especially if they're having, for example, cancer pain or other symptoms that are due to the burden of cancer. So I think that's something where, it's been very encouraging in terms of seeing how quickly these may work for patients. I think that also supportive care approaches, such as growth factor drugs that can help to mitigate some of the hematologic toxicities are important. And so thinking about those up front in terms of, who are those patients that may benefit from not just the ADC, but with the addition of growth factor or other ways of supporting their blood counts may improve their symptoms or potential symptoms that could occur. But again, I think, just as an example, I've had some patients who had very significant cancer-related pain, and within a week of starting treatment had a very dramatic improvement in those symptoms. And so again, I think this is something that, we've needed something like that for a long time, and seeing that the data that's coming out suggesting that that the antibody-drug conjugates seem to be providing a very rapid responses, and many patients getting benefit from these, even in more hard-to-treat patient populations, such as those patients who have received prior lines of therapy or have platinum refractory disease. Well, thank you so much for being with us today. It was really a pleasure to share the updates in terms of the antibody-drug conjugate space, and look forward to having a chance to hopefully talk more in the future.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through independent educational grants from Daiichi Sankyo Incorporated and Merck Co. Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/XYC860.